Hey guys, want to shoot a quick video of the questions that were posted today. And all of those questions stemmed from some of the posts that I made on Instagram this week with the handheld dynamometer showing the changes in strength after stretching, changes in strength, increasing strength with palpation techniques that we use with 180 system. And so here are the longer explanations. Since you guys are in this group, I can actually post a long video with content instead of talking a million miles an hour for a minute. So evidence-based practice, why I don't care about evidence-based practice, I don't read research and all that stuff. That's what I used to do when I was a student, and that's what I thought I needed to do in order to learn more. What I figured out was I was just cherry picking the studies that fed my bias, because you can find a study that says anything you want. You can find a study that says the world is flat. You can find a study that the wall behind me is green. You can take any study and make it say anything you want, and that's what people do, and then they hang on to that, and that's what sends them down the wrong road. And the problem with physical therapy and this whole evidence-based practice garbage that was pushed into schools when I was in school is that the overwhelming majority of it has absolutely nothing to do with clinical skills. It has nothing to do with critical thinking. It has nothing to do with getting functional results. It's a bunch of garbage that people do to get a PhD and publish crap that really doesn't have any weight once you hit the clinic. So my favorite thing to talk about when people talk about evidence-based practice is that you can find hundreds of studies. Every single study that's ever been done on stretching and whether it increases range of motion, and every single study will tell you that stretching increases range of motion. Who cares? What it doesn't tell you is why stretching increases range of motion, why massage increases range of motion, why foam rolling increases range of motion. If we actually looked at the physiological aspects of what is happening, we would understand that those things increase passive range of motion and active range of motion too, because it's sacrificing neuromuscular function and strength and stability. That's what the important thing is. So I don't care how many studies you show me telling me the positive effects of things that increase range of motion, because I will tell you, I went to school and I learned physiology. And when you look at things like neuromuscular junctions and afferent efferent pathways and muscle spindles and inhibitory interneurons, things that you should know off the top of your head, those will all tell you that stretching, foam rolling, massage, all that junk that increases passive range of motion is a negative and should not be done. So that's why I don't care about your evidence-based practice. And when people say, well, I want to see your evidence-based practice and all the studies that you've published on the 180 system, never going to see it. You know how many independent variables there would be if I did a study on the 180 system? It would be endless. We would get nothing done. But I can say, when I pick up my 180 system manual and there's 150 sources cited there, and most of those are physiology books that you learned what you know from in school, that is accepted science. Everything within the 180 system is built on 100% accepted science that you cannot debunk. And that is the reason why patients get better on a functional level, and that's why we don't have to chase symptoms. So science-based practice is what we do here, not evidence-based practice, and those are two completely different things. And if you keep chasing evidence-based practice and reading research, you're going to get further and further ingrained and stuck and burnt out in the clinical medical model. Number two, when you are assessing a muscle for normal neuromuscular function, you're doing a neuromuscular facilitation test, which is what we do for everything here. If you keep on assessing it, it's going to fade and get weaker and weaker and weaker, actually more inhibited, not weaker. So that is what is happening. Why do we know that? Why will you know that once you take the shift? Because you're going to take an hour-long neuromuscular physiological review that will show you, remind you what you learned in school, and that supports the reason why that muscle tests weaker, actually more inhibited. And if you're testing a muscle that has normal facilitation and you keep on testing it, it will test stronger until it finally fatigues. Number 3. So a lot of people watch my videos and say, well, you're telling the patient, you're going to tell the patient, you're going to be weak or you can't do something, and then I'm going to touch a magic button, and then all of a sudden you're going to be able to do something. False. If you've ever watched me treat patients, you will see that I don't explain anything to a new patient until after they feel the difference between inhibition and normal facilitation, until they feel the difference between strong and weak, stable and unstable, stiff and tight. Once they feel the difference and they look at me and they say, what the hell did you just do? Then I go into science. Then I go into, let's say I'm doing a sitting toe touch and they can't touch their toes and they got low back pain and tight hamstrings. I don't say, I'm gonna touch a magic spot and it's gonna get better. I say nothing. I'm gonna say, okay, lay back down. I'm gonna palpate their pyramidalis. I'm gonna get them back up. I'm gonna have them redo their toe touch. They're gonna go 6 inches further. They'll have no back pain. They will have no hamstring tightness. And that is when I explain to them the law of reciprocal inhibition, which everybody in a physical therapy clinic should be using on a regular basis with every single patient. But my bet is, if you don't use the 180 system, you don't even remember what that was. So I explain nothing. I bias my patients none. I do what I do. I let them feel the difference between pre and post tests. They see their increase in range of motion. They see their increase in strength. They see their pain go away, even though I didn't do anything to get rid of their pain. And that's when they say, explain that to me. And that's when I explain science. And then the last one, if you look anywhere about stretching and how long the effects of stretching last and how long the inhibition lasts, it's at least an hour. So when when people want to argue with me and say, well, you can stretch and then, the strength is going to come back. Okay, I don't know too many athletes that want to stretch and then hang out for an hour before they go do something. I don't know too many patients that want to come in and have me stretch them so they get worse and then go sit in their car for an hour before their muscles turn back on. That's ridiculous. So if you go into a gas station with half a tank of gas, do you just fill up the gas tank? Or do you siphon out all of that gas and then start from scratch? Why in the world would you make somebody worse and start from scratch and then make your job harder and make them worse and make it longer for them to recover when all you have to do is figure out what's inhibited, reverse the inhibition, strength comes back, pain goes away, range of motion gets bigger, stability is better, bingo. Piece of cake. It's that easy. Stop making your job so damn hard. Evaluate everything, assess science, get to the root cause, reverse the root cause. Don't dance around tightness and pain and all the mumbo jumbo symptom modification crap. Get to the root cause, reverse the root cause, move forward, educate your patients about science instead of telling them fairy tales and nocebos about evidence-based practice.